coordinate training and professional development and workforce development for our own staff, and also helping to build the capacity of health jurisdictions through the training that we are coordinating for the Healthy Communities work in the Department of Health through the section of Community and Family Health. I became involved with the WSPHA Professional Development Group through a contact with John Britt probably approximately 8 to 9 months ago. And so working with John, we decided that a topic of interest, a topic of interest to many of you, is around multi-sector partnerships. So today you're going to hear from 3 folks in Washington State related to multi-sector partnerships. And when I began recruiting people to be part of this presentation, we looked at a statewide partnership, so you'll hear from our first presenter about that. And we were looking to maybe a well-established partnership with a long history, and the second presentation will be about that. And finally, hearing from a local community in terms of a fairly newly developing partnership. So let me introduce our first presenter. What we will do is about 15 to 20 minutes on each of these partnerships, presentation by the representative of that organization. And then if you have burning questions, we can take them at the end of that presentation, but I would prefer that we wait to do any questions and answers until after we've heard all 3 of the presenters. So with that, let's move to our first presentation from Don Sloma. Currently, Don Sloma is working for the Comprehensive Health Education Foundation in Seattle, and he is working on a statewide partnership, the Healthy Communities Partnership, actually under the auspices of the Department of Health, some funding that they've received, that we in the Department of Health have received to do this work. Don has a long history of other public health work, but we're going to, in lieu of best use of time, we're going to just move to his presentation. So, Don?
Okay, well, good afternoon, everyone. Happy to be with you today. We are technologically disadvantaged in this office. We're not on the webinar setup, so I'm going to have to ask that someone who can control the slides handle the slides for this presentation. We can't manipulate them. The first slide should be up now saying Washington's Developing Healthy Communities Partnership. Is that right?
Everybody else is muted, Don.
Oh, is everyone else? Okay.
Yeah, we just need to move.
Don, yes, this is Betsy.
Okay, well,
just tell me to click when you want me to go to the next slide.
All right, very good. Well, okay, so on this first slide, I just wanted to let you know that currently I am working with the Comprehensive Health Education Foundation on a contract through the State Health Department to basically set this partnership up. And we can move to the second slide. What I'll be talking about today is what the partnership's purpose is, the desired outcomes, members, staffing, progress to date, the work remaining, and some lessons learned. We can move to the next slide. You should be looking at a slide that says Healthy Communities Partnership Purpose. The partnership developed a charter that was approved just in January, so we've only been working on this project. Well, we worked on this project for about half of last year, and we finally convened a partnership steering committee at the end of 2010, and one of the first orders of business was to get a charter together. So what you're seeing on this slide is there right out of the charter statement. It is to build broad consensus among public and private organizations around community practice changes that increase the ease with which Washingtonians can improve nutrition, physical activity, and reduce smoking, and particularly in communities facing disproportionate burdens of chronic disease. Move to the next slide. You should be looking at one that talks about intended outcomes. Specific community practice change recommendations are essentially the primary outcomes in this phase. Also, though, we want to be doing some public promotion of recommendations, including public and targeted communication about those recommendations. And we want to, bottom line is to increase the ease with which healthy nutrition, exercise, tobacco use choices can be made in work at school or in community environments. So all of this should be pretty familiar to those of you doing Healthy Communities work. Next slide, please. 15, HCP Steering Committee members. The way this is intended to develop and be structured is there is this steering committee, and I want to say a few words about how it is comprised. And the intention is to create an open membership beyond this steering committee of other organizations, state, local, public, private, in order to expand this partnership. The thinking was the steering committee needed to do some steering first and get some focus and identify some policy priorities, and then use that so that there was a more specific reason for people to join than the broad statements I've been sharing so far. So we're in that process right now. Our co-chairs are in keeping with the health department's view that this thing should be a public-private partnership, should be very broad in its base, and that it should be a consensus, centrist sort of activity. There is a co-chair from the public sector, Aline Morris, who I believe is maybe listening on this call, as well as Donna Stewart from the Association of Washington Business. So we were very intentional about picking public-private representatives at the top level of this partnership from the beginning. That group, those two, I should say, met with us and others and developed the remainder of the steering committee with a fair amount of concern to be sure that there was a balance that was comfortable for the public and private sector in terms of the relative weighting of the various groups that you see represented here. So I won't go through and name them all, but I will tell you can see their names and their associations there. I'm happy to take questions about what this maybe looks like, or why we did or didn't go ahead with others. But this is the mix we have right now. The idea was to keep the group small enough to be manageable, so it wasn't an opportunity to have a group, a steering committee at least, that would include everyone who might have an interest, but rather try to get a group that could focus an effort for broader engagement later. I guess the only other thing I would say about this is if you'd like to know a little bit more about who these people are, we have all of this material on a website, which I will be sharing the link for later in this presentation. And hopefully we can go there during this presentation, and you can take a look at the bios and pictures of these folks, as well as some of the background material that we've been putting together so far. So moving on from there, we can move down to the slide that talks about staffing and support, some of the nuts and bolts that might be of more interest to some of you who are trying to put things like this together. We have 20 months startup funding from the federal stimulus grant. It's the CDC portion of the Communities Putting Prevention to Work, and it comes through the State Health Department to us. That's enough to support a part-time professional staff, some web development and administration, some other administrative support. When we began this project, it was part of the Healthy State campaign at the Washington Health Foundation, and just as of January of this year, the project and I moved to the Comprehensive Health Education Foundation. Same project, different letterhead. We have subcontracts now. We did during a research and development phase last year with Chef and Uncommon Solutions, and we continue to rely for some support for the meetings and some of the process on Uncommon Solutions as well. Some of you may know that private contractor. Last year when we were putting this together, we made extensive use of interns in order to put together a bunch of the background research, and we did a fair amount of blogging last year to try to drum up some interest, and they helped with that. And I would certainly recommend that way for people who are trying to do this on a budget less generous than the one that we have for this startup phase. Steering committee members are also providing in kind. Our steering committee members are the Association of Washington Business, for example, is letting us use their executive conference room for many of our meetings. The health department sponsored a webinar, and we got the SPI to help us with sponsorship of one of their facilities, and this is sort of, I imagine, not uncommon in the development of these partnerships. And we've also enjoyed very generous consultation and administrative support from the state health department. So we've been able to rely on the brains and the research at the state health department. That's been incredibly helpful to us. So we can move forward to the next slide that will talk about our progress to date. Last year, we did spend a fair amount of time, rather than just picking the folks that we thought would be the usual suspects in the logical group, understanding that we wanted to reach out for a broader base. We spent a fair amount of time interviewing more than 100 people who are key players around some of these issues around the state in order to determine some things about their assumptions, interests, attitudes, and willingness to participate in a partnership like this. I'll be sharing some top-level summary of that later in the presentation. We have determined a scope, a focus, and a general approach to the work. We have formed the partnership and developed the steering committee membership that I've already shared with you. We set up our web log and our web page communication platform, and we're communicating on a regular basis with interested members. And any of you, by the way, who wants to get on that mailing list, please let us know, or go to our website, just send me an email, and we'll see to it that you get on the list so you can get regular updates on the work that we're doing. As I said, we have a steering committee charter approved, and our basic work plan and process parameters defined for what this steering committee will be trying to do in the next few months, or through the remainder of the year, actually. So to the next slide, more on the HCP progress. Our initial focus areas have been tentatively identified, and we have potential roles tentatively identified. And right now, this is right where we are in our process. It appears that we will be focusing on school-age children's nutrition and physical activity, and selected community access to healthy foods issues and worksite wellness issues. What exactly the policy or community practice initiatives may be within those three areas, we're still sort of determining that, although there's some interest in focusing on healthy breakfasts as one way, looking at the expansions and the changes in the school nutrition program and the free and reduced lunch, breakfast program through SPI, as well as some other opportunities that we may have through the Restaurant Association, as well as through some of the retail groceries around the state, and perhaps other community partners as well. Our potential role it seems to be emerging at this point, and this, again, is not at all final. This is sort of where thinking seems to be, as nearly as I can determine right now, and it's public communication campaign, advocacy, and coordination across, as you all know, I'm sure there are many local, many state groups that are working on healthy communities work and in these three areas. And I think the steering committee sees a role for itself in helping to coordinate, communicate across some of those groups, and also to try to facilitate as much consensus as we possibly can. And that's one keyword that seems to be a byword of this coalition, is that we want to find those things that we can get broad agreement on across all these sectors. Let's move to the next slide and talk about work remaining, and it's a considerable amount. We still need to finalize, as you can tell, focus areas, an action agenda, and our intended role from the material that I just shared with you. We need to engage in some outreach with our potential broader partnership and make sure that we actually have a broad base moving forward. We do have communication with more than 100, I think it's about 150 people right now on a regular basis that representing different organizations. You know, a mile wide, and we're not sure of whether an inch or a mile deep yet, and we want to make sure that that gets a little bit deeper before we go too much further. We think we need to have something to share with them before we ask. So that's why we're doing this. We need to obtain financial support. The intention here, I believe, is if we do find consensus on some of these issues, that this thing have a support base that lives at least as much in the private sector as it does in the public sector. We don't want to fall prey to what has happened in the past, where some of these broad-based coalitions are closely enough beholden to public agencies that when the advocacy part of this work starts, the organization doesn't have the wherewithal to carry forward with its policy agenda. And we think that the tactic there is to make sure that there's sufficient private sector support for this work, which is what sort of led us in this direction. And I will say, you sacrifice something when you go for breadth. in terms of progressive or cutting-edge policies. We're hoping that we can build something that may not be the brightest or most progressive group in the community, but one that represents that broad middle. We'll need to evaluate the startup effort that we're hoping to complete by the end of this year. So if you want to learn more about the partnership, here's the way to get in there. On the next slide, we'll tell you about our website. You can simply go to www.chef.org. I think you can maybe click on it right now. I don't know. Somebody advised me about whether people can do that if they want to now, because I kind of like to do that for just a moment before I complete the last few slides.
Hi, Don. This is Betsy. I think what I will have to do is I can pull it up on my own, but I don't think that we can have people click on it.
All right. Let me just leave this slide with you, and I'll move on then. Those who are interested in this website can go there, and if you get to the Healthy Communities Partnership portion of the Chef website, you will find the charter, you will find bios on all of the members, you will find all of the documents that we have used in our meetings so far, and you will find a version of regular updates on the work that we've done. And we do our best to try to keep this up to speed. If any of you would like to join to get on our regular mailing list, please just send me an email, dons@chef.org, and I'll be happy to put you on the regular constant contact email distributions. I usually try not to hit people too often. Once a month or so is about what we try to do to send you those. So I want to just complete this very quickly. I'm told I have 5 minutes, and I want to just run through the bulk of the work that we did last year, which was a survey of 122 key organizations. We can move to the slide about lessons learned after the other slide that has our website. And you see there the mix of businesses, healthcare provider groups, philanthropies, community organizations, and others that we tried to survey. We won't represent this to be anything representative about attitudes and opinions across Washington residents. This was an intentionally selected sample to reflect opinions in that group of people that surrounds policy and community practice leadership in the state around these issues. And I would not for a minute suggest that this is representative in any particular way, other than what we felt was the universe of organizations that might have to agree if anything was on a basis. But let me share, having said that, let me share with you the next few slides. So let's move to lessons learned, healthy choices, and social influence. Virtually everyone in the sample that we had anyway believed that health choices are socially influenced, which was good news. But most believe government or communities should make healthy choices easy, which was all very good news for the health department and for our own efforts at the Healthy Estate campaign, where I worked when we started this, because that's the language we've been using. People like that language, it seems, all the way across the board. We had almost no one tell us that that wasn't a worthy thing to try to do. However, there's fewer who support government bans on unhealthy options. So let's move to the next slide quickly and dig a little bit more into that. Respondents were divided. A few would focus on clinical preventive screenings to detect disease risks early and to educate patients. More would focus on individual risky behaviors, through smoking, cessation, diet, or exercise programs. But most of our respondents favored policy environmental change. I would say most, but it is significant how the sample split on that. It was most, if you look at the sample we had 49 community organizations, only a few businesses, only a few insurance companies, only a few health provider groups. And so whether or not we would have consensus on moving forward policy and environmental change was something we had a real question about. There does seem to be a real division, even among people who know this stuff, about, and who are healthcare providers, about whether this should be all about, for right now, individual health education and clinical screening. Should it be about individual behaviors, or should there be something more done in terms of policy, environmental, and community-wide change? Let's move to the next slide. The very best news about the survey that we did was Of the respondents that we had responses from on this question, virtually everyone told us, and we gave them the option to say that health disparities were the responsibility either of the individual or of the ethnic or racial or income group that these people belong to who experience disparities, or that there was a broader community responsibility. You can see the graph in response to that. Virtually everyone said there was a broader community responsibility. So that is something that was very good news for us in moving forward. We are, of course, are going to explore what that means now as we try to develop the partnership. Second to last slide, I believe, is environmental survey conclusions. A large degree of support for better nutrition and physical education standards in school, some broad cross-sector interest in employee wellness. Legal restrictions, though, remain unwanted among certain groups, particularly in the business sector. So we literally have a circumstance here where we have the business community and some insurance groups and many of the clinical folks who are interested in this still question what legal restrictions might add to this conversation and a sort of predisposition that they may not be necessary or desirable. And the final slide is about political polarization and partnerships. I suppose if there's any takeaway I have to share with all of you, having done this survey last year and trying to put this together, I would say there are both sides with very strong ideological divisions about whether, quote, collective action or, quote, individual responsibility is the way forward issues. And unlike when I was working for state government, and even in the Healthy State campaign 8 or 9 years ago now, or 7 years ago, whatever it was, there's even deeper and better organized divisions about this issue than then. I hope this isn't news to many of you out there, but I have to say it makes the environment much more difficult. There's more widespread comfort with clinical and programmatic interventions. Nobody really disagrees about the value of that. I think there's a disagreement about whether that's sufficient. Policy changes, especially, except perhaps with regard to tobacco, where people seem much more comfortable with seeing policy changes. There seems to be really quite a bit more division about whether they're, certain of those policy changes are really desirable or necessary or properly timed at this point. And the next point is, fear and holding on the campaign trail. Everybody is hunkered down right now protecting their values, whether it's ideological or the kind of programs they believe work, or the money that they currently control that relates to this. So it really does make the environment very, very difficult to work in, and it makes consensus pretty hard to find on many of these issues. And finally, we do believe, and I think we're beginning to see that trust is building slowly, but only to the extent that everyone who's sitting at the table sees their own future in whatever's developed. So to the extent we bring things to the table that one group or another feels they can't take back to their members and get support for, or to their more natural constituencies, we find non-starters. Well, that concludes the prepared remarks I have, except I would say to those who find this a little bit depressing or perhaps a little hard to listen to, here's a little perspective I would offer you in conclusion. Apparently the first clinical trial was conducted by a British Navy captain who commanded 4 ships on a voyage from England to India in 1603. He gave one crew a spoonful of lemon juice each day, and those on the other 3 ships didn't get any. 40% of the control ship crews died. None on the experimental crew did. The British Navy received reports of that experiment in the year following and resolved to make public policy for the British Navy right away. And that policy finally became British Navy law in 1797. This is slow work.
Okay, thank you, Don. We're going to move on to our second presenter, who is Maria Carlos. Maria is the Program Manager of the Infant Mortality Prevention Program at Public Health Seattle and King County, where she's been employed since 1989. Prior to that, she worked 11 years for the March of Dimes in many western states. Maria actually has a co-presenter, and I will let the two of you introduce Bob. So Maria, you may begin.
can you hear me?
Yes?
Okay, I'm going to try doing this. All I have is audio. Sorry, we're having technical difficulties here in Seattle. So Bob and I together have been a part of this multi-sector partnership for over 20 years. I've been the public health representative off and on over the 20 years, and Bob Putch has been a representative from the community. If Bob's on the line, I'll let him introduce himself.
I'm here, Maria. You want me to get started?
Go ahead and just introduce yourself, and then I'll introduce our topic and let you start.
I'm a retired internist, and I've been in and out of Seattle ever since this program started. So both when I was living there and ever since. So go ahead, Maria.
All right. So together we've been a part of a multi-sector partnership called the Seattle Infant Mortality Task Force. And recently it became the Equal Start Community Coalition, which is why you see those two names on the first slide. We're going to talk to you about its evolution, its history, and some of the lessons learned from this 20 years of experience. Okay, Bob, next slide.
You'll see beginnings from 1990 to 1995 when we first got started. The slide actually shows infant mortality rates in King County from 1981 to 2008. And I think there's a flaw in it. I suspect that the Native American Indian and Alaskan Native rates in the 80s were probably higher than they are reported on this slide. This resulted in a really well-meaning and well-focused effort by Children's Hospital, who got a grant, next slide, to put together some meetings about these issues. The grant eventuated in 2 successful regional meetings a year apart. There were stakeholders in the community that just simply couldn't afford to miss. I can tell you that they involved people from multiple sectors, health, human services, education, community members, advocacy people, policymakers, foundations, outreach workers. The purpose of these meetings was to develop multi-sector strategies and involve groups that we thought were in positions to actually develop solutions. There were organizational efforts to undertake legislative action, and it was impossible to go to one of these meetings without going away with a designated task to be reported upon the next year. We had some good community leadership involved in the Seattle-King County area. Next slide. The key was the grant funding early on. The 2 summits worked. They paid for coordination of staff, funding for meeting spaces, reporting, mailing, printing, all that sort of thing. Next slide. But they didn't pay for worker bees. And during this time, just by chance, a trouble case occurred at the University Hospital. I can tell you, report how this all came down simply because we've reported publicly and the university people have. I happen to be a professor there myself, a professor emeritus now. That just means I'm an old guy. It has nothing to do with merit. Anyway, they had a case that was videotaped, and it turned into a serious problem between the community and the institution. There were 2 solutions proposed, and one of them was to do cultural competency training. At that time, I had just gotten grant funding from Kellogg Foundation. They said, oh, you know, we got to go to the Kellogg people, and I looked at this and said, boy, I'm not going to do it unless there's actually a negotiation. The negotiation was based on a power shift. The trouble case actually gave some power to the community. There was an implied threat of going to the Office of Civil Rights. And case resolution in this instance was really based on cases that have been reported from Canada. There's been a literature in Canada about trouble cases and doing work between communities and institutions. Next slide. So there was leadership from the community. A lot of oversight was provided for outreach workers. Over time, we had a lot of changes in membership. At times, the meetings would dwindle in size, and then they'd build back up again. There were 3 or 4 years in which there was absolutely no funding for the task force, and we were frustrated by our inability to act on outreach worker reports. For example, when they'd come in and say that a shelter had shut down. And then Maria will tell you about her own reactions to this and the role that the public health department was thrown into. Maria?
So public health's role was really to be a member of this task force over time and to provide logistical support, and when the institution said they wanted to pay for the equivalent of 1 FTE of an outreach worker, they distributed it through us, through public health. So we were really the bureaucracy that was supporting the effort, but we were meant to remain neutral and just a neutral member that supported this community effort. Bob keeps reminding me that it's hard to remain neutral when you're a witness, and I just have to tell you, it was hard to remain neutral. Next slide. So things continued in this rocky way, but pretty quietly until about 2008, 2009. In early 2009, the task force went through some strategic planning to come up with a mission and a goal, and came up with the mission to promote healthy mothers, healthy families, and healthy communities through its goal of reducing racial disparities in infant mortality. And we changed our name at that point to become the Equal Start Community Coalition and expanded membership to about 30 organizational stakeholders who represent, again, healthcare, outreach workers, so community-based organizations that hire outreach workers, social service agencies, DSHS, advocacy groups, the Native American Women's Dialogue on Infant Mortality, quite a few organizational stakeholders, but sort of still your usual suspects. But because we're looking at reducing racial disparities in infant mortality and understanding that it's upstream social determinants of health that are resulting in these disparities, we're looking also to reach out to other sectors, including child welfare, criminal justice, economic development, more people from education and the early learning community, and from business. The coalition has embarked on having its meetings be more educational in focus. We've had education about best practices for services to women of childbearing age and to families. The coalition has invited folks from doing the child death review. Actually, folks doing being involved in child death review in our county are on the coalition, and so we've invited them to talk about child death and infant death investigations and what happens there, what information is learned there. And the coalition is looking to have another summit in September called Fulfilling the Dream for Our Children. And we had a successful kickoff to that summit in January of this year, inviting Kamara Jones to be the keynote speaker and Maxine Hayes to also be a keynote. Senator Claudia Kaufman spoke, as did Paula Marinin from the Children's Alliance, and 80 people from a variety of sectors attended. It was a successful kickoff. Next slide, please. So the funding for the Equal Start Community Coalition still is tough. Funding really comes from public health, which doesn't provide cash. It just provides in-kind staff support. Essentially, it's my job to provide support to the coalition. We have a student, Masters of Public Health student, who takes great notes for us and makes sure that we've got a record of what we've been doing. We have very little project funding, although we've written about 6 or 7 grants. We haven't gotten those grants, so very little funding. But the funding for the outreach workers remains. That funding comes from the City of Seattle, a little tiny bit of state public health funding, and from the institution that put funding into the community-based outreach worker, a FTE of a community-based outreach worker some years ago. Their funding continues every year, and they represent about 20% of the outreach worker effort that we've got going in our county. So that's no small thing. Next slide. So 20 years of experience, we believe, have had some positive outcomes. We're proud of a number of things. We've had 2 summits. Of course, that was 20 years ago, but we're very hopeful for the summit that's happening this fall. And we had a successful kickoff and we have quite a planning group working on the summit in September. Primarily, the focus of our work is that women receive support and maintain prenatal services, and that has continued through the entire 20 years. The outreach workers at community-based organizations are reaching women who are the hardest of the hard, living in the hardest of the hard circumstances, who wouldn't ordinarily avail themselves of public health or community clinic safety net services. And they are being reached, and they are provided support and get services. Another positive outcome is that the community has remained committed. That probably is the most humbling thing to me, that for over 20 years, community members continue to come and be a part of this coalition. We've had committed leadership and committed membership throughout the 20 years. There are community-based organizations that have maintained membership from the beginning. We've had 2 leaders. Bob is one. Elizabeth Thomas was the other, who were our leaders for 20 years. And throughout that time, we've talked about expanding, and we're at a moment when we are expanding now, which is quite exciting. Next slide, please. So at the moment, we have new leaders. Bob and Liz have been saying for years they needed to retire, and 4 people have stepped forward to serve as an executive committee to replace them. It takes 4 people to fill their shoes. We have new excitement with new membership, and the new membership has embarked on some advocacy, certainly around state budget this year and last year and other things. We had a successful summit, as I mentioned before, attended by 80 people from many sectors, which is evidence of current enthusiasm. But these positive outcomes didn't come without some challenges, and I'll let Bob tell you about those with the next slide.
The whole time that we've been doing this work, there have been power struggles. They've occurred between institutions in the community. They've occurred inside of institutions. And we've discovered that institutional commitment depends very much on individuals. From time to time, we've had spectacular leadership. We had the director of the University of Washington Hospitals at our meetings every 3 months for almost 4 years. We've had a lot of ebb and flow of group members, and throughout the whole time we've had really variable activity to, ability to act on the outreach workers' reports of ongoing problems. We've had difficulty sustaining funding. A lot of times we haven't had any funding except for the settlement. There was, I should tell you, part of that power struggle early on in the early 90s. At the end of the negotiation, one of the agreements was that the university would provide monies for outreach workers. Those funds were spread amongst the group of community coalitions that were employing outreach workers, and it allowed both the university hospitals and the communities to be more engaged with each other. That funding is still ongoing, as Maria told you. It pays for about 20% of the work. The other message has been that time-limited training, for example, cultural competency training, it's interesting, but in my view, it doesn't make change. And it's It's necessary, but I also think that if you really are going to affect change, there are some questions about how you deal with the power differential. It makes it very difficult to formalize an oversight system, to review outcomes in the target communities. And we've had over and over again the experience of trouble cases, without exception. Almost every time we have a meeting, there's a new problem with another hospital or another place in town. It's been an interesting circumstance, but a frustrating one from the perspective of ability to respond. So the unintended consequences is that trouble cases don't stop. If you'll turn to the next slide. The funding source that we currently carry all the time was negotiated. There have been threats to it every time there have been cuts in the university budget. They want to shut off this money, and we've had a struggle over it. There's been problems about controlling and sharing outreach workers. Who are they working for? It's an interesting circumstance when you have multiple people and multiple groups involved. Public scrutiny and action is difficult to sustain or even get started, and maintain the focus with new people is difficult. So partly because I think that the institutions and the groups involved are, well, some of them are kind of written in stone. Change is resisted. So I'll let Maria talk to you about that.
So the next slide, under lessons learned of our 20 years experience, while change is resisted, the folks in power don't want to give up power. Persistence does pay off. And that's a lesson that has been hard learned, but it does pay off. Change happens with the times, especially if we're resilient and change with the times. Community work takes time, and it changes over time. Bob asked me, did I think that the excitement and enthusiasm that's happening right now this year would have happened without the literature that's now showing that it's the social determinants that affect health outcomes? I know that the community has remained committed. People know that their health is compromised because of many things that are not health related. But now public health is sort of catching up to that notion. And then that means that other people, other folks are interested in becoming involved. Balancing power with and coercion, as Bob mentioned, there was that threat of coercion 20 years ago, but balancing it with power is a lesson that we learned, that you don't always need to do that. You can use power sometimes. It's important. A strong lesson that we've learned is that it's important to maintain trust and relationship. You maintain trust through relationships, but that takes time and persistence. And I would say on the part of public health, what it takes is just showing up, attending every meeting, being there, being a presence, not necessarily taking over, but listening, being witness, providing support when we can, but being there at every meeting helps to maintain the trust of the community. And you can't have a relationship unless you're there. So showing up is probably, we should have said that in the slide, showing up. Also, consistent leadership is key. Partly for the memory, so our leaders knew what happened 20 years ago, but that memory helps with the persistence, so that when we lose focus, they bring us back to remember what we're doing, remember why we're doing this, remember who our focus is. Next slide, more about lessons learned. Our leaders showed us this, that there needs to be a balance between realism and optimism. It's real easy to, especially for me, I try to be a positive person, always positive. It's helpful to have some realism there when us optimists get a little too carried away. But it's also helpful to have the optimist to remind the realists when they get discouraged that there's a reason that we're doing this and we can do it, to sort of motivate each other. So leadership keeps each other real and motivated. A lesson that we learned was to take advantage of the momentum and the enthusiasm as it is there, as it happens, and take advantage of opportunities. As an example, we wrote a large grant proposal for a large amount of money to have a summit that required us to partner with a number of people. So we began relationships with others to expand our net. And while that grant was pending, while we were waiting to hear about it, we just started planning the summit. We ended up not getting that grant, but we had momentum. And so we just continued to plan, figured out how to do something without the funding, and had a kickoff. Now we're seeking funding for the summit again, but we used the momentum that was happening, took advantage of the momentum as it occurred. I mentioned or hinted earlier that our leaders kept us focused on the center, and that was a lesson that was important, to keep us focused on what was important. What was important was community. And when our leaders reminded me of that, I understood that what was not important was public health, but public health's role was to support community and to keep women and babies, women and their families, at the center of our focus. And always knowing that sort of kept us going. We also learned, really the hard way, that motivation comes from many sources, and some of those aren't so positive. We mentioned a trouble case. We mentioned the possibility or potential for coercion. We also, recently, one of our leaders died, and we're all still grieving her loss. But that also provides us with a source of motivation. We keep thinking, what would Liz do? We want to live up to the legacy that Liz left. So motivation comes from many sources. Next slide. We have some lingering questions, which Bob will talk about.
Well, I sometimes think that my thinking comes from the dark side of the force, or that I look at the dark side of the force. I sometimes wonder how often real change can occur or be sustained without a shift in the dynamic of power. I don't know the answer to that, but it was clear that coercion played a role early on in what we did. We agreed that neither side would go to a legal solution, although it was a close call, or an attempted legal solution. And it raises questions about how communities can initiate change. I know of, this is the second time in the 20-year lifespan, or 25, 30-year lifespan for me in Seattle, in which we've used coercion. We used the Office of Civil Rights to get the language bank started when people were being seen without interpreters. So that wasn't a spontaneous do-good work or, gee, we need to do this on anybody's part. It took some arm twisting. So it also raises questions about, you know, do health departments make change, or do they need partnerships? And a lot of these questions that I've listed are just what they are. I don't know the answers to them. It's just they're lingering questions and observations. And then the focus of work efforts need to shift as causal explanations change. And I think that Maria talked about that very nicely, especially around the literature about social determinants of health and what are the underlying causes of high levels of infant mortality. And also the question is, have we made a difference? As you'll see, African American rates are down. If you'll put on the next slide, please. African American rates are down somewhat, but they're still twice that of white, Hispanic, and Asian Pacific Island groups. Native American rates are still high. And all I can say is we're still doing the work. And I like Don's comment earlier on in his presentation. You just have to stick at it. And if we can go to the next two slides quickly, the last slide memorializes this presentation. Elizabeth Thomas, a nurse practitioner who recently died, and one of the many lessons we learned from her was simply never give up the struggle. Thanks.
Thanks, Bob and Maria. Let's move on to our last presenter, who is Tara Hano. Tara attended Eastern Washington University and has worked in public health in both Oregon and Washington for over 5 years. She's currently the Healthy Communities Coordinator for Pacific County in Long Beach, Washington. Tara, go ahead.
Great, thank you. I have to say that after the last two presenters, I feel a little bit like an infant or a toddler in these stages. But I was approached by Danny to give an overview of the landscape of partnerships in our rural community, and just to talk a little bit about where the rubber meets the road and what reality looks like for us in Long Beach and in South Bend, Washington. So I work for Pacific County Public Health, and 2 years ago we were selected by the Washington State Department of Health to participate in a project to specifically prevent chronic diseases and basically look at the impact of chronic diseases and the development of chronic diseases in our community. And currently we're at the tail end of that second year. And go ahead and go to the next slide. To give you a little bit of a foundation or a background for our work, this is the vision of our coalition, and basically the purpose of our project and the action steps that we take in our community. We're hoping to ensure that all citizens of Pacific County have access to healthy foods, are physically active, mentally and emotionally well, and live, work, learn, and play in toxin-free environments. So in order to accomplish this work, next slide, we're specifically looking at policy development, environmental and systems changes, and looking at lifestyle programs and how to address some of that work in order to create healthy living or healthier residents in our community. So next slide. So again, not to hit things home too hard, but our desired outcome is to improve the health and quality of life of our community. Specifically, we're looking at 3 main risk factors, which Dawn actually talked about as well: tobacco use, physical inactivity, and unhealthy eating. And in order to accomplish this, we realized at the very beginning, and we were also mandated by the Department of Health to really include our community. And in order to do that, we specifically approached several different community partners. Many of them had been partners of ours in the past, and some of them were new partners. And we realized that as an organization, we couldn't address all of these risk factors in a meaningful way without including the community. So next slide. So the purpose of our partnerships, we believe, and why we have included our partners, and I would just like to say that our partners aren't just faces at a table or names on a memorandum of understanding. They actually are ones that are making decisions and getting their hands dirty as well. So we believe that these partnerships build lasting change and community investment. We believe that they ensure that the community voice is being heard and that we're addressing the appropriate risk factors or addressing the appropriate systems. We've spent a lot of time over the last 2 years building these relationships and trying to understand each specific organization or person's motivations in order to strengthen that partnership and to ensure that we're being specific and I guess capitalizing on the opportunity of the partnership, if that makes sense. We also believe that these partnerships consolidate our efforts and that we aren't duplicating efforts. We realized when we all kind of came to the table and we began reaching out to the community that we were doing similar work or we had similar goals in mind. And so we have realized over the last 2 years that really there is strength in numbers, and that a lot of our efforts can be, especially in these these times of uncertain budgets, that consolidating efforts is important, and not duplicating efforts is also important to make sure that we're being efficient. And then again, just to ensure sustainability so that the change will stay even if the funding is gone or specific people or entities are gone. So next slide. These are just a few of our partners, and I didn't put specific names of the organizations, but I'll talk a little bit about how they've been partners. We have several parents and parent groups. And there's a specific group that's like the PTA at the elementary school that has been really important to our work when we're looking at our school lunches and increasing access to fruits and vegetables in our school lunches. And one of our parents is actually a hairdresser, and so she is amazing how much work she can get done while she's cutting people's hair. And we've had several individuals show up to meetings that she has specifically invited while she's doing their hair. So it's been exciting. And then law enforcement, we have the chief of police and deputies that are involved in our coalition. And when we were doing our assessment of walking and biking around our local elementary schools, our chief of police was there in uniform helping us look at the safety issues and walking around the neighborhood with us. So that was an awesome opportunity to just build a personal relationship with him, but to get to know what his motivations were as well. Then we have youth serving organizations, and specifically the Boys and Girls Club is involved with our work in developing a summer lunch program. And we have a local organic farmer that comes to our meetings and is involved on our healthy foods team. And we have several different volunteer organizations, the Rotary, the Kiwanis, the Elks. At the school district level, we have a superintendent, a principal, a couple of teachers, a youth, and then we have the prevention interventionist. At the community hospital level, we have a nurse, a registered dietitian, and the human resources director who's involved in creating worksite wellness at the hospital. And we have other community coalitions, specifically the Wellspring Community Network, which is a network that has been funded through a Drug-Free Communities grant, and is specifically looking at reducing substance use or prevention of substance use in our community. And that coalition is a really great way for us to network and just share information about what we're doing and sort of look at sort of that consolidating efforts or making sure that we're not duplicating efforts. And I didn't list this on the slide, but we also have local businesses that are involved. We have a local computer web design business that has been working with us on our web page and some other activities. And then we have a couple of insurance agents that are involved as well. And then at the city administration level, we have a city planner, and we also have the city has also funded a specific program, which I'll talk about next. So go to the next slide. I shouldn't have. I spoke too soon. So after I get done managing our partnerships, I'll talk about a specific program that the city is involved in. So who manages these partnerships and navigates these relationships? I'm the community coordinator along with a fellow cohort. And together, her and I are really the staff that support the general day-to-day duties, coalition coordination, facilitation. And then we have a leadership team, which really acts as the steering committee to the coalition and ensures that we're moving forward, looking at the data in order to drive our work. So I sit on that leadership team. We have several other department administration that sit on that team, and then we have one community member that also sits on that steering committee. And then we have team leads. So we've divided some of this work into specific teams, and we have leaders that are coalition members that lead those teams, and they have several different various members as well. So we have the physical activity team, the toxin-free team, the nutrition team, and then we've had a couple of ad hoc teams that have just come about for specific projects. And these teams are really more action-oriented and not so involved in the steering or the day-to-day staffing of the partnerships. They're really more getting the work done in the community. So next slide. Some of the positive outcomes of these partnerships have been creative or innovative actions. And one of those actions is that the City of Long Beach has established a local farmers market, which we're excited about because it opens this week. So we're hoping to have that be successful not only for the city for economic stability and sort of tourist dollars, but also to have it increase access to fruits and vegetables for the local residents in our community. We've had a student who's doing his senior project or culminating project develop a comprehensive trail map, which is a map that is just one map. Instead of having to look at several different maps, you can just go to this one map, and it includes the biking and hiking trails in our community. And then again, we're developing a summer lunch program, and the Boys and Girls Club and the Elks have been amazing in helping us establish that. And this year we also did an assessment of our school lunch program, and we had various people involved in that. Other positive outcomes were that we've had broad community awareness and involvement, and that the community has taken responsibility and ownership for some of this work. We feel that we're able to sustain the work, that we've had greater accomplishments. When we originally looked at our work plan 2 years ago, I think we felt like we were a little bit lofty and we bit off more than we can chew. But over the last 2 years, we've really accomplished more than I think even we expected that we could have done. And we've built lots of diverse partnerships as well. And then we've had funding opportunities that have arisen because of our partnerships. So whether it be a federal grant or foundation, oftentimes it seems as though they're looking for communities to have already developed those partnerships and to show community involvement in order to fund the program. So this has created a lot of excitement and energy. So next slide. So it hasn't always been easy. The challenges that we've faced have been the community coordination. It seems like navigating so many different voices and ideas and motivations, and just in general, personal relationships can be challenging, and it takes finesse. Continued partner education. It seems like every month we have new people at the table, which is a good thing, but it also takes time to bring them along to what the goals and the mission of the organization is. And then historically, our organization has conducted programs and implemented curriculum in the community, and so it's been a tough transition not only for us as an organization, but also for the community to understand the difference between programs and systems change. So that's been kind of a huge hurdle that we're still learning ourselves. Addressing community expectations. So when the community heard that we received funding, I think they expected that either we would be distributing that funding through mini grants, or they expected to see new programs or new things in the community. And I think that a lot of the work was happening behind the scenes. So oftentimes they had a different expectation, and it wasn't that we weren't meeting their expectation, but they often didn't see that work behind the scenes. And then as the other presenters have expressed, real change takes time, and that there's many steps to having a policy implemented or enforced, and that we kind of have to realize that and be real about that, and to kind of let go of that control. Next slide. Oh, that's the end. Thank you. So if anyone has any questions with my contact information.
Thanks, Tara. Betsy, at this point, I'm going to let you manage the questions since I'm actually not able to see the questions.
Well, I would.
So we're ready for questions.
So please, if you do have any questions for our presenters, please type them in now in your question box, and we will start asking them. Right now, we don't have any at the moment.
Well, maybe if people don't have questions, does anybody have comments they want to share?
Well, if people think of questions and they decide that they would like to ask after the end of the presentation, the PowerPoint will be up on the website, and the contact information for each presenter is in there. And you can also email them to me at my WSPHA email account, and I'd be happy to forward them to anyone if you think of questions going forward.
If there are no questions or comments, I again want to thank all three of the presenters. It takes some effort to put all your comments and thinking together and to share that with everyone. And I think personally I achieved what I hoped, in that we could hear from a large public health agency, a small public health agency, and a statewide approach, and different levels of maturity with partnerships. So hopefully it provided some interesting information for folks and things to think about.
We'll give people another minute or two as I introduce the slide for the June webinar. We'll have our next webinar on June 1st, and it will be about setting local public health priorities. So please keep your eyes open for the email and join us on June 1st.